So moving on, allow me to briefly introduce today's speaker. Dr. Gregory Koury was born and raised in Albuquerque, New Mexico, and is a 1983 graduate of the University of Notre Dame, as seen on the back of his chair there, and a 1989 graduate of the University of New Mexico School of Medicine. Following medical school, he pursued his family practice residency at Memorial Hospital in South Bend, Indiana, where he later established a private practice. In 2003, Dr. Koury relocated to Silver City, New Mexico, where he and his wife, Lori, a registered nurse, built a successful practice blending the philosophies of an old country doctor with modern medical technology. Described by a patient as providing womb-to-tomb care, Dr. Koury offers comprehensive medical services for newborns, pediatric, and adult patients. Transitioning to a direct primary care model in 2015, Dr. Koury remains dedicated to delivering patient-centered care and continues to enjoy a fulfilling career alongside his wife, Lori, who together they share their joy with 8 children, a number of grandchildren, and an array of beloved pets. With that said, Dr. Koury, thank you very much for joining us today, and the floor is yours.
Thank you very much. I'd like to thank the Consortium for the invitation and opportunity to speak in regards to direct primary care. As you said, my past, I am born and raised New Mexican. Went to high school in Albuquerque, spent a lot of time in Santa Fe, and escaped to Notre Dame, came back to UNM. I went to UNM during, they had the 2 primary tracks. We had a traditional and the non-traditional tracks at that time. I did the traditional, knew I wanted to go into family medicine, and primarily went back to South Bend because it was a non-competitive residency. There were no other resident programs there, so it was only family practice. Stayed in Indiana simply because back then it was, I think it was Dr. Orr was Health and Human Secretary for Reagan, and Indiana was a nice place to be a family doctor. So I stayed in Indiana, Southern Indiana, for several years. And then my wife unfortunately came down with rheumatoid arthritis, and we found that the cold winters were no good for her. And I also believe that once New Mexican, you always come back. So I came back to New Mexico, and Silver City was a good choice. Nice small town. They had a need for primary care. I was still doing the traditional medicine then, insurance. And over the next few years, my wife is an RN, so we're essentially partners. She was doing all the insurance side, filing, refiling, fighting with insurance companies for the next few years. And we found that to be very, very difficult, became more difficult. I found that I was not enjoying family medicine. And I got turned on to direct primary care in 2014 by Dr. Brian Forrest out of Apex, North Carolina. And he was a family practice resident that went right into direct primary care out of residency. And he had been doing it for several years. He's actually involved with the AAFP, the American Academy of Family Practice. And I went to one of his conferences, got excited. I saw a different way to do the business side of medicine. And that next year, my wife and I switched over to direct primary care. We transitioned all the way over. We did not do a hybrid. We one day took insurance, the next day we didn't. And essentially, direct primary care is it's a patient financial model where it's directly between physician and patient. I sort of call it concierge light. We're not that expensive. My fee is only $49 a month to be a member. So that's relatively inexpensive, affordable. but it allowed the business side of medicine that I could actually spend more time now with patients. My wife could spend more time with her patients as an RN. And it very quickly, within a few months, we found that we really enjoyed primary care medicine again. And we found patients that liked this kind of model also. A more direct involvement with their doctor. We found insurance was no longer in the office, was no longer in the room with us. And we actually found patients were more compliant, more effective with their healthcare, more involved with their healthcare, given this direct model. Couple things of one thing I say about it, the best of DPC is that you own it. You make the decisions. You take care of your patients the best that you can. The worst part of it is you own it. You make all the decisions. It's both. But I like that. Our patients also like the idea that they have more privacy at this office, is that they don't have someone else looking at their chart. Insurance is not looking over things. I'm finding a lot of patients are looking for that privacy now. They don't want everyone knowing about their medical history. So that's the basic presentation, and I will sort of open it up real quick if there are people that have specific questions, something they're looking for about direct primary care. See if anyone has a question.
All right, Dr. Koury, I'll go ahead and go first and kind of kick things off and hopefully inspire others to jump in. Can you differentiate between pure and hybrid DPC models?
So yeah, the pure meaning that you go completely no insurance within the office, no Medicare, Medicaid. We don't participate with any programs. The hybrid, a lot of folks who do make the transition or come out of residency will do a hybrid where they'll say, I'm not going to take the regular insurance folks, but I'll take Medicare and Medicaid. So you have both programs within your business model. A lot of folks do the hybrid in that they don't take any insurance, but they'll take Medicare. And so that makes up a hybrid. So I know several practices that do that on a regular basis. I find most practices do it as a transition because it does take a little bit of a financial hit. It takes a little time to get up and running, just as it does when you get out of residency and you start in a practice. I think Medicare doesn't pay you for 6 months of filings. It takes that long for you to get on there. So our pure model is no insurance within the office. So the distinction there is that a lot of our folks do have insurance, especially down here in the mining community. They have actually very good insurance. So they can use DPC as a primary care. But then if they have any necessities outside of that, an X-ray, ER evaluation, a referral, then their insurance works. So it's not like a patient is coming into DPC and they're giving up their insurance if they don't want to. They can still have insurance, and that we do the primary care at a reasonable fee. And so a lot of folks like that. We do have quite a few people that still have no insurance, that don't carry insurance at all. And of course, then the DPC model is ideal for them.
I see that Carrie has her hand raised.
Hi, thank you so much. I'm Carrie Shaver. I'm board president of the New Mexico Rural Health Association. I'm very glad to be here. We just completed a listening tour talking to rural and frontier stakeholders regarding healthcare in New Mexico. And one of the top things we found was concerns around access. So I was curious if you thought that this direct care model had a place for rural New Mexico, and could assist perhaps with that healthcare access in the primary care space.
Yes, I think it's actually a very effective model for access. Given I'm not driven by insurance, I'm not spending that extra time trying to file, refile. I actually can see patients within a day or two. Our telemedicine is quite vibrant with DPC, and that patients can get hold of me. And now with the way computers are and phones are, especially skin rashes, those can be seen and taken care of without having to be at the office. But for rural, we're essentially rural out here. I take care of a lot of folks in Southwest New Mexico. I have patients as far as Animas, and it's ideal for them that they can get hold of me, send me a message, send me a picture, and they don't have to drive 2 hours to a clinic. And so for access, I think the DPC model is ideal.
I think it's really wonderful what you're doing, and I do have a million questions. I'm glad you talked about telehealth. So you are active in the telehealth space and are able to navigate the technological requirements?
Yes, ma'am.
And have you thought about integrated behavioral health in with your practice?
Probably could say I haven't thought about it. I probably do it. And that we do say that when it comes to family practice, probably 60% of our practice is actually mental health, not physical health.
Right.
So we actually spend more time. That's where access is difficult, is for mental health down here. Our hospital used to have a mental health department, and they closed it about 2 to 3 years ago. So with the DPC model, and there's an additional fee for that extra time, but people are glad to come in. We'll spend 30, 45 minutes on mental health. If there's more specifics to depression, anxiety, especially after the last 3 years, people are coming unwound. So we spend extra time with those patients. We work it into our clinic hours.
Are you prescribing medication for opioid use disorder, or do you have any substance misuse care that you're providing?
No, that I don't specifically do.
And I'm sorry if I really do have 80 million questions. If I should speak to you alone, I completely understand that. So I apologize to everyone.
No, quite. Actually, it's my belief that this will actually generate more answers to people by getting questions like this. And rather than me just trying to cover it all. So.
We are an advocacy organization. We're a state affiliate of the National Rural Health Association. I'm not sure if you're familiar with it. It has a national platform focused exclusively on rural access issues, research, et cetera. And we do that at the New Mexican level. For direct primary care, what would you want an organization like ours doing advocacy around and education around? Like, what would be helpful for you and your peers?
I believe it's just the education of what is direct primary care, and that it simply is a business model, but it translates into providing better medical care. But helping people understand it's not concierge. A lot of times we hear DPC, they think concierge, and they think it's $300 or $400 a month or several thousand a year, and that's not us. That's not what we do. I'm not in this to be wealthy. And I do this out of the desire is to practice good medicine, but doing it without all the hassles of the insurance and the government getting into medical care. I don't think they should be in the office. Not good for doctors, not good for patients.
I should just say my background is healthcare administration, so this, I have a keen interest in efficiency and provision and access for folks. So I really appreciate your presentation.
Yeah, but I think just getting that out to people that they understand. I think a lot of folks just have they don't understand exactly what we are, and just giving the folks that they have a different way they can access medical care, and it's not that expensive. I think a lot of folks just think it's too darn expensive, or they have to give up their insurance, and those aren't true. It's just getting the word out. I'm not sure how many DPC doctors are in New Mexico. I don't think it's a lot, because even on my side, on the professional side, most doctors and practitioners don't understand what DPC is either.
Right. I was wondering, are there any regulatory or legislative issues that serve as barriers to starting up as a direct care provider?
No, ma'am. Probably the only specific contract we have in the DPC model is with Medicare patients. And that, of course, our government doesn't quite like us because we don't participate with Medicare. So they came up with lots of rules and lots of wordings that we have to follow. So there is a contract that Medicare patients have to sign once a year that says that they're going to a DPC doctor and says that I'm not going to file for any Medicare money. And it's just something you have to have on their chart. Otherwise, you don't have to have any specifics for patients. And I had mentioned Dr. Brian Forrest. He is a great resource since he's been doing this now for, I'm going to guess, 35 years. And that his is called Access Healthcare. And you can find his website just putting that in, Access Healthcare and Dr. Brian Forrest. Okay. And he actually helps other DPC doctors. He keeps up with all the regulations, keeps up with the government, and he'll let us know if something changes. Keep an eye out for this. But the Medicare contract is actually the only thing we have to watch out for.
And then are there nurse practitioners functioning in this space as well?
Yes, nurse practitioners can do this business model also. I don't know of any down here or in New Mexico. But yes, I know there are some, I think in Arizona, there are some nurse practitioners doing a DPC model.
I'm also, in addition to board president of the New Mexico Rural Health Association, I'm also a health administration researcher. from Texas Tech University Health Sciences Center. So I don't know if you or any of your peers would be interested in looking at outcomes or financial pieces. If you wanted to have that research done, I know I could pull some colleagues together who'd be interested in looking at this, especially in that Medicare population.
I think that would be useful. Again, educating professionals that this is a viable option, that they can look at their business model and actually make things better for themselves and their patients. But having numbers would probably help make that decision.
I'm throwing my email in the chat, so if you wanted to connect, then we certainly could discuss that further. It seems to me that this is something that the National Rural Health Association would be really interested in learning more about, especially as it comes, especially around those issues again to access. Are you doing anything in the workforce development space? Do you have any recommendations on that labor shortage around PCPs?
No, I've not been involved with that. Again, as a DPC doctor, given my peers don't quite understand what I do and how I do it, it's hard to get them to understand what I'm doing. So I've not been involved with workforce development. I know down here, every business is lacking people. I know our hospital's lacking professionals. But no, I've not been involved at that level. They all think I'm a little funny.
And then your fees is that $49 a month per individual, or do you have a family fee structure?
Correct. Yeah, it's $49 per member. The maximum is 4 for a family. So we have some families that have 6 and 7 in their family, but we only charge 4. So that's our max. Yeah, and they can do that as a monthly or as a yearly one-time charge. We do have what's called a booking fee, and that's a $25 booking fee. So it's sort of like a copay when you come in for a visit. What's unique there is that we're DPC through Dr. Forrest is joint ventured with LabCorp. And so I can do labs in my office. They're drawn here, processed, LabCorp picks them up. But I can do a chemistry, a CBC, a lipid profile, each of those for under $3.
Oh my goodness.
And that comes out of the booking fee.
Wow,
so
that's
I'm
wonderful.
taking that booking fee, and then that's how I'm paying if we do labs and such. But essentially, like I said, it's like a copay type thing. But then we can do all the labs right here. We don't send people out. We don't send the lab request to their insurance. We keep it in-house.
And then what's your capacity for patients? How many folks or families are you able to accommodate?
So what we try to stay is about 900 to 1,000. So probably about half of what a family doctor has to do in the traditional model. I think the numbers say that a family doctor has to have about 2,500 on their panel. We're about half of that. And we do that again so the care is better. We have more time in the office with each individual patient. Our office appointments are minimum 15, average 30 minutes. So
that's extraordinary.
excuse me?
I said that's extraordinary. That's what a wonderful opportunity for patients to have that connection with their PCP and that relationship.
Yeah. And for the professionals that are listening on the fear side, you think you do this and your patients will just inundate you and your phone will never stop ringing and you'll never go to sleep. It's nice is that actually, since it's a direct relationship, patients actually have a lot of respect for my time, just as I have a lot of respect for their time. And so I do get the after hours calls, but most of the time those are for children. And so it's parents who are going, nope, something happened to my child. But I'm not getting the adults calling after hours and this kind of thing. So as I said, when I switched to DPC, life became much nicer. My wife will tell you I'm a much happier doctor. And we found that our patients are much happier.
In terms of folks providing this kind of direct care, do you see any other professions or disciplines like optometry or dentistry engaging in this kind of work?
I could see more of the primary care models doing it. So yes, those, again, and I actually have seen a few specialists. There's a couple specialists in Texas that have gone. There's an ENT that has a DPC model. Don't know of any specialists that are doing that in New Mexico, but yeah, definitely dentistry, optometry, sort of that primary care could easily do this business model. Again, it's an education thing. It's them understanding that, yes, you can still make a living and actually do a better job.
Thank you so much for your patience with me. I'm going to be quiet so other people have an opportunity.
No, I greatly appreciate the questions. Like I said, it generates lots more discussion, and I'd have a difficult time just sitting here talking, and probably everyone would get bored. So.
Hi, Melo. My name is Virginia Perez. I'm from Mountain View Hospital. I guess listen to you and listen the prices that you manage. My main question would be, how do you run? This is a private practice with low cost to afford it. I don't know if that makes sense.
I'm sorry, could you say again, please?
So basically, knowing the prices that you handle in the office, including the laboratories and the cost of the visit, how do you run the business and sustain it, basically?
Oh, so it's that you can imagine that if you have 900 members, and that's $49 per member, you can figure the math. I'd have to figure it out. Can't think off the fly. So if someone's got a calculator. So you're actually getting $44,000 day one of each month. And then throughout the month, you have your booking fees for appointments. Your payout then is the lab fees, and our lab fees are usually no more than about $1,500 a month. I've got malpractice. I've got a guy that works out front. I've got my wife, so I have to pay her too. But when you eliminate all that time you have to spend filing insurance, that's gone. So like I said, this is a very affordable way to make a living and practice really good medical care without distraction.
I'm sorry, I'm new on the system, but I guess that if the insurance is out of the equation, I guess it's affordable, basically.
I'm sorry, I didn't get that.
In other words, if we take out the insurance from the equation, everything matches.
Right.
Dr. Koury, jumping off that question, how do you determine the price for the area that you're serving?
Dr. Forrest actually did that for me back in 2015. So back then it was actually 39. And in 2019, we increased to 49. So Dr. Forrest, and he had a fee for that. I paid him for his time, but he looks at the service area, he looks at the socioeconomic region, and he came up with that price of, back then, 2015, of $39 a month per member. Like if you go on to Dr. Forrest's website, his membership, he's got a 3-tier membership now. And I think he starts at 69, goes to 79, goes to 89. And his tiers are depending on what kind of services people want. Given he's been doing it for so much longer, I think that's why. And he's in a much bigger area. He's in Apex, which is like the triangle of North Carolina, Durham and that area. So much bigger population, a lot of corporations there. So yeah, I think his maximum, he does an $89 a month membership is his biggest one. So it was made, that was decided for here. And so, yeah, there was some work put into that. I should say, I mentioned corporation, is that I've actually joint ventured with corporations here too, in that folks who have, or businesses that have several several employees, they'll actually come to us for that DPC model also. And this is how they access their primary care for their employees. So you could actually present this model to businesses.
What would be an example of the type of business that you would partner with for something like that?
Well, the one business we've joint ventured with is a gentleman who owns several of the grocery stores here in the county. And so with him, and that he has probably a couple hundred employees, and he offers it just as a option to their employees if they want to access this model, and then he will pay their membership fee for this one. So it helps him, so it helps that owner, and that he's not having to get traditional insurance for his whole employee group. He can actually use the DPC model. More affordable.
I thought I saw Carrie with her hand up, but I don't see it anymore. Did you have a question?
I have lots of questions, but I was done asking. I just think it's an extraordinary model, and what I keep thinking about is how do we get more folks doing this so that we can reduce access issues in rural and frontier New Mexico? And then secondly, how do we make prescribing for opioid use disorder in particular attractive to DCPs? Because we have such a shortage of folks willing to prescribe buprenorphine, for example, to folks who have opioid use disorder.
I would think it's just getting it out there. I know down here we only have, I'm not even sure. See, I don't even know, as a primary care doctor in Grant County, I don't even know if we have anyone who's doing opioid disorder.
Yeah, I'm not certain either. That's why it's so important to have it in primary care. And of course, you don't have to do the X waiver anymore. That was a huge barrier to prescribers. Recently, right, was that you had all these other DEA
Right.
issues and the X waiver, et cetera.
Yeah, I think for our area, HMS was doing it for a while with a couple of their practitioners, but things have changed at HMS. I'm not sure what they're doing now in that regard. But I think some of that's education, that not hearing anything coming out of the medical society or the family practice organization encouraging or educating professionals to pursue the opioid disorder. I know for myself, yeah, probably didn't pursue it simply because the way it started, you had to be certified, or that there was paperwork. And I know that's changed, but I don't see anything out there now encouraging doctors to get involved.
Have you thought about taking on other staff that would be providers, especially advanced practice nurses specifically? I'm thinking of FNPs. Has that been a consideration for you at all?
At this time, no. Haven't been looking at that. My office is fairly small and built more just for one practitioner. So yeah, had not pursued that. When I had my practice in Indiana, I had nurse practitioners at that time, but when I returned to New Mexico, I didn't pursue that.
Just as an aside, I think it's funny, I'm in Indianapolis right now. I split my time between Las Cruces and Indiana. So I thought it was really funny to have that connection with you there, because I am, in Indiana as we speak. So just thought that was funny.
Yeah. I was a Hoosier for far too many years.
I'm looking forward to New Mexican only time in the future, certainly.
Yeah, I was down in Lawrenceburg, Indiana for several years on the Ohio.
Sure. I was with Indiana University for 13 years and managed a healthcare pipeline workforce initiative. And so that was part of my region. So I'm very familiar.
Yeah. We enjoyed Indiana for the time we were there, but it was nice to come back to New Mexico.
All right. Do we have any other questions?
I think Carrie's questions actually generated a lot of the things I put down, so that was good.
I'm so glad, and I would love to connect further. So please email me. I hope you're interested in developing further relationship with New Mexico Rural Health Association, because I do see this as what could be a key part of addressing those health equity issues in rural frontier New Mexico.
Yeah. We're not going anywhere. We like where we're at, and rural is, the big city's nice to visit, but don't want to live there. Can you send me your email again?
Sure, I dropped it in the chat, but I will respond to the initial email that invited me to this presentation. And then if it could be forwarded, that would be fantastic.
Great. Yeah. Oh, I appreciate your time. Thank you for the questions.
My absolute pleasure. Thank you.
All right. Dr. Koury, one more question.
Yes.
In terms of getting started, we have residents are going to be graduating soon. What would be the process for kind of like, all right, I want to look into starting my own DPC clinic? What would be the process for doing something like that?
Yeah. Well, I'd probably recommend definitely contacting a DPC doctor. do a one-on-one, get some information. I do know the American Academy of Family Practice does have a DPC teaching resource. So it's within the AAFP. The other is how I did it, and that's with Dr. Brian Forrest. And that he is a staunch advocate of DPC. He's done it quite well. He is the expert, and contacting him directly. And I think he still does this where he actually brings people in. Of course, there's a fee for it, but he does an intense education on DPC, how to do it right, and how to make it work.
All right. And then in terms of gathering patients, like how did you go about getting essentially your panel of patients? Like was it word of mouth? Did you do advertisement, things like that? What sort of
combination of both down here in Silver City. We have a paper called the Desert Exposure. So we advertised in there. We did do a little advertisement in the Silver City newspaper, and word of mouth, of course, once people are coming in. But I'd say it was probably just the newspaper and the Desert Exposure. And it's just like any practice. I think this would happen for any resident coming out and starting with a clinic or starting their own office. It's just, you got to open the door and get the word out by word of mouth and people talking. And if you keep the door open, they will come.
I have a question, Dr. Koury. You said you switched from like one day to the other, and I'm just wondering, what that impact was on the patients. Did you have to do any education through that, or what did that look like?
Right. Yeah. We did have to tell patients over several weeks that we were going to be changing models, that it would be this direct primary care. And of course, we had lots of folks who said they had to stay with their traditional insurance. They either didn't quite understand or simply said they couldn't afford that, or didn't want to be doing both DPC and insurance. And a lot of folks stayed with us. So it was just educating people about DPC in the office, telling them directly. And then our website also has a couple of pages on there that talks about DPC, the difference between traditional and direct primary care. But yeah, it was one of those things we just had to, we didn't want to do that hybrid idea of just fading out of insurance. We let people know over several weeks that we were going to be one day this, next day that.
Thank you.
Thank you.
All right. Do we have any other questions?
What does your work week look like with that panel of patients? What would be typical for you?
Oh, that's Monday, Tuesday, Thursday are full days. So that's 9 to 4:30. Friday, just in the mornings. Wednesday, occasionally in the morning. Otherwise, I am a old-fashioned doctor in that on Wednesday afternoon, I play golf. Otherwise, I do see patients. I do home visits throughout the week. I see patients in the office on the weekend for acute care. And that's here and there. But that's what's nice about having this kind of model. I have that freedom to make that choice and that time to see the patient outside of regular office hours. So every week varies, but it's reasonable, not out of control.
Thank you so much.
Thank you.
All right. Any final questions for Dr. Koury?
Well, I hope this was helpful for everyone, and I hope this was helpful for your group, Mario. Maybe we'll turn some people on to some primary care with DPC.
Most definitely. All right. With that said, Dr. Koury, thank you very much for joining us today, and everyone have a great rest of your day.
Thank you very much.